Hello everyone. Hi, welcome to the ASEAN ACC 2022. My name is Dr. Leong. I'm from Institute Jantung Negara, Malaysia, and I would like to welcome you to this ASEAN ACH conference, whereby we intend to improve ACH care in the region via education. Right, this week's topic is on Ebstein anomaly in adults, and we have two interesting lectures followed by a case-based learning, where we're going to put the two speakers on a hot seat where we're going to bombard them with questions. But before we start, we'd like to get your cooperation. We'd like to do a little bit of housekeeping announcement. Please leave all your questions and answers at the end of the talk. And because we want to make sure that we cover all the lectures and case-based presentation. Second, please mute yourself because any unintended interruption will interfere with the smooth sailing of this webinar. And if you have any burning question, please click on the chat box and post it. Or you all want to raise any question personally, do raise your hands using the icon down below. Right, we're going to get things started. The first talk is going to be delivered by Professor Tarini Tangcharion. She's a consultant in cardiac MRI and an ACHD cardiologist at the Ramathibodi Hospital, Maidol University. She is the CMR Cardiac MRI Director and also Director of the ACHD Clinic at the Ramathibodi Hospital, Bangkok. And she has published more than a dozen research papers in cardiac MRI. And today she's going to talk to us something which is very close to heart, which is on the long-term follow-up of patients with Ebstein's anomaly. Dr. Tarini, over to you.
Thank you so much, Dr. Liang. Thank you so much for a kind invitation. And first of all, I'm not a professor yet, okay? I'm just associate professor. Okay, let me share my slide. Can you see my slide?
Yes.
Oh, great, okay,
yes,
yeah.
You can see that clearly.
So first, I'm just associate professor, not professor, but thank you so much, okay? Okay, so we're going to talk about the long-term follow-up of patients with Ebstein. And okay, let me do something. Laser, okay. So I'm going to talk about what to expect in adult patients with Ebstein anomaly and how to follow up and when to do intervention. So we all know that it has been 150 years since Wilhelm Ebstein first described the patient is 19 years old scientific man. But actually Ebstein is a rare disease. It happened in just 1 in 200,000 live births. So the number is not much. However, because we have a very high technology, we have lots of patients who are, survive into adulthood. And I try to look at what to expect in adult congenital heart disease with Ebstein. And I found this interesting paper come from Australia. And you can see the number is not much, just 51 patients, because, Ebstein is not a very common congenital heart like pathology follow. So this center, they follow up for a long time. Let's say that 20 years in 51 patients. And interestingly, actually, almost 1/3 patients were diagnosed first at the age after 16 years. So actually, most of the patients with Ebstein anomaly first died during adulthood. And we look at the overall survival, and you can see that actually survival is very good. Most of the patients survive until, 40 years follow-up. This is a survival to the age 40 years is almost 100%, and for 60 years is 81%. But actually, story is different when you look at the arrhythmia and the freedom from tricuspid valve surgery. If you look at arrhythmia, if you can remember, at the age 40, 100 patients, 100% of the patients survive. But in arrhythmia, it's not the same story. Actually, during follow-up, 1/3 of the patient underwent catheter ablation, and most of the patients have the, SVT or A-flat or atrial tachycardia. And we look at the freedom from tricuspid valve surgery is almost the different story from survival curve. You can see that actually most of the patients have tricuspid valve surgery for symptom, and they can have bone repair and replacement. And the time between diagnosis and surgery was 20 plus minus 13 years, and the median is almost 24 years. So as adult cardiologists, we have to decide which patient will have, tricuspid valve surgery, which patient will not have. And the other interesting paper just came out, 2 years ago, is a long-term follow-up again, and this time this group, I think it's from Mayo group, they follow up patients for 53 patients and follow up for 12 or 10 minus plus 10 years. Interestingly, actually 29% of the patients have sudden death. So, not just atrial fibrillation or atrial flutter or SVT, the patients are high risk for sudden death also. And of course, the patient can develop arrhythmia. And you can see that the patient with arrhythmia, they have less survival rate compared with the patient without arrhythmia. So you can sum up that actually common problems in adult patients with Ebstein anomaly is two problems, arrhythmia and tricuspid valve. So we come to the first topic, arrhythmia in Ebstein anomaly. Well, the first thing you have to ask, what is the most common arrhythmia and when should we do the catheter ablation? And the most important thing for me, I think, is who is the high risk for sudden death in Ebstein anomaly? So the first question, what is the common arrhythmia in patients with Ebstein anomaly? Well, you can look at the 2020 AC guideline and you can see that with Ebstein anomaly, of course, everyone knows that Ebstein anomaly have multiple accessory pathways. So the most common is AVRT, but again, with the sudden death, you can see that the chance that the patient will have the sudden death is not less than pathology of Fallot. So this is a common arrhythmia in Ebstein anomaly, SVT, or sudden death. Of course, some patient after operation, you can have, pacemaker because you have the acquired sinus node dysfunction or AV block. Well, then come the second problem. Well, if you have this patient, this is the real patient, 26 years old, and she comes with this, Ebstein anomaly with this ECG. So you can see that the patient have a, delta wave like this, okay, short PR, delta wave. Clearly, the patient have accessory pathway. But the problem is that what should we do first if the patient is asymptomatic or if the patient is symptomatic? Well, if you look at the guideline, you have two guidelines from both transatlantic, 2018 from America and 2020 from ESC. So actually in America, you can see that if the patient have, Ebstein or with a pre-excitation on the ECG surface, well, even the patient doesn't have the supraventricular tachycardia, they recommend to do the EP study with or without catheter ablation. But you should do the EP study because actually with the accessory pathway, you can have the high risk accessory pathway, which means that, the atrial can, go through the pathway very fast. And if the patient have atrial fibrillation, well, you can have the ventricular fibrillation later or VT, VTAC. So you have to define which one is the high risk, accessory pathway. And the only way to define is to do the EP study. That's why they recommend that if adult with congenital, Ebstein anomaly and ventricular pre-excitation on the surface ECG, you should do the EP study. And then if you do the EP study, well, if the patient must have the surgical intervention, they recommend that the EP study should be performed before the surgical intervention. Of course, if the patient have the high-risk pathway or multiple accessory pathway, catheter ablation is recommended. This is from United States. Well, look at the European guideline. So actually, it's not different much. If you have a symptomatic arrhythmia or you have pre-excitation on the ECG, well, they recommend the EP study and followed by ablation therapy. You can see the difference here that even the pre-excitation on the ECG, EP study, and then ablation therapy. Okay. I think that the only problem for the EP study in Ebstein is that accessory pathway in Ebstein, well, does not come in one pathway. Normally, you have multiple pathway, and you have challenges during catheter ablation. If you have time to see the paper, I recommend you to read. It's very, very good. Well, this is all the challenges during catheter ablation. First, with the anatomy, it's really difficult. Sometimes even I have a patient who's sent to the EP lab, and electrophysiologists cannot perform the ablation because anatomy is very difficult to maneuver the catheter to guide to ablation. So this is all the challenges you confront with the Ebstein anomaly with accessory pathway. Well, the first question, if you have the, pre-excitation, you should the EP study. But the most important question, I think that the answer has not come clear yet, is what about the sudden death in patients with Ebstein anomaly? Well, this paper just published 4 years ago, and their follow-up, you can see a lot of patients. This is Mayo Clinic, so that's why they have almost 1,000 patients and follow-up for 13 years. And look at all the incidents of, you can see that they use the word sudden death, not sudden cardiac death, because sometimes it's difficult to define, sudden cardiac death. So this is just a sudden death. But when they calculate the risk of sudden death, you can see that the more you grow older, especially if you reach the age of 50 years, the risk of sudden death is almost 10%. And if you can remember, 100 patients of the patient with Ebstein anomaly can survive until 40 years old. So they have more and more risk of sudden death. Interestingly, actually, when they looked at the multivariable Cox proportional hazard model to look at which predictors associated with a sudden death, and they found that, of course, heart failure, ventricular tachycardia, and this is very interesting with the tricuspid valve surgery, also the risk for sudden death. Well, some comments that because this is a long-term follow-up and because maybe this is an old technique of tricuspid valve surgery, or maybe the patients are very, very at a functional class, not good during the surgery. That's why tricuspid valve surgery also is a risk for predict the sudden death in Ebstein anomaly. Heart failure, I'm not surprised, because if you look at adult non-congenital heart, if you have the heart failure, that is a very bad predictor for the sudden death also, and also the ventricular tachycardia. But again, even if you just look at the factor that affect the sudden death in the patients who are following the tricuspid valve surgery, well, the predictors are the same: heart failure, ventricular tachycardia, and also the pulmonary valve stenosis. Well, I think that the most important thing for me, I'm quite interested because, if you look at the patients who got the ICD and they look at the primary prevention and secondary prevention. Well, everyone knows that secondary prevention means that the patients are survivors for sudden cardiac death. But you look at the inappropriate shock and appropriate shocks, of course, if you insert the ICD for the patients for secondary prevention, the appropriate shocks is, numbers are very good. But look at the primary prevention. Well, for the primary preventions, actually, there are no appropriate shocks, and fall happen with the inappropriate shocks. I think that's why when you come to the role of ICD in the ESC guideline for congenital heart, you can see that actually the classification, there's one is only in secondary prevention, which means that if the congenital patient who are survivors of abort cardiac arrest due to VF or hemodynamically altered VT, when you look at the primary prevention for ICD implantation, actually they looked at the ejection fraction actually they copy from non-congenital adult patients. Well, they look at ejection fraction, they look at New York Heart classification. And then if you have the still, it's just 2A recommendation, okay? So the role of ICD in Ebstein anomaly for primary prevention, well, sadly, I have to say that until now, we don't have the role for primary prevention, just secondary prevention if the patients abort from cardiac arrest. Well, for arrhythmia, I think that we will go for the next topic is about the tricuspid valve surgery. And I think that when we have the patients in the clinic, for question that we should, ask ourselves, when should we do the surgery? And if we do the surgery, which surgical technique, replacement or repair? And then when should we follow up? And how's about the tricuspid valve reoperation? I think that for the guideline, it's pretty clear that, okay, you can do, if you come from the, United States, you can do the surgical repair or reoperation if the patient have the symptoms in severe TR, significant TR, heart failure symptoms, or, you have the progressive RV systolic dysfunction by echo or CMR. And with Ebstein anomaly, I think that everyone knows that it's not just the valve problems, but actually it's the right ventricle myocardium problems also. So it's myopathy in terms of congenital heart disease. So many times we confront with the patients with both, RV dysfunction and also significant TR. And then the surgeon has to do the Glenn operation just to, relieve the volume from the right ventricle. So they recommend that the Glenn anastomosis at the time repair may be considered, but first you have to check that the LV function is good and left atrial pressure must be good, not too high, and LV and diastolic pressure are not elevated before you decide to do the Glenn operation. And I think that it is not different much with ESC guideline that surgical is a class 1 recommendation in patient with a severe TR. And if the patient have the symptoms and for the ESC guideline, they're quite pretty clear that they should be performed in a congenital surgeon with specific experience. I think that for our region in Southeast Asia with limited number of congenital surgeons, this is quite very bold statement. And sometimes I went to the conference in our region, and some surgeon asked, "What do you think about the just CVT surgeon perform congenital surgery?" Well, I always say that I believe that the congenital surgeon will do the best thing, but I know that it's quite different for quite difficult in our region. Okay, so and then what kind of surgery we're going to do? Replacement like this one, this is MR. The patient's got the bioprosthetic valve replacement or repair. This is our patient after the cone surgery, and this is a 3D tricuspid valve. Well, I think that if you can, the guideline recommend repair. But in my experience, many times we send the patient to the to the theater, to the surgical room, and the surgeons try to do repair, but anatomy is not it's quite not suitable for the cone operation. I think that we will listen more from the next talk about the cone operation. So most of our patients, adult patients, end up with a tricuspid valve replacement, and we're lucky that we have this one with the cone repair with a very, very good, result. Well, when you try to look at the paper that look at the outcomes of operation, compare between the replacement and repair. And again, the biggest data came from Mayo Clinic. They've established the congenital heart for a long time. So that's why they have almost, 540 patients with Ebstein anomaly. I think that's very, very much unbeatable actually. And 539 patients with Ebstein anomaly. And they follow up the patient with tricuspid valve repair or replacement. And even if you have repair and then you have to change to replacement, they just consider this group as intention to treat. So they consider as a repair. And they follow up for a long time, almost 34 years. Interestingly, actually, they divide patients into the early and late complication. And of course, early complication, you have the atrial arrhythmia, low cardiac output, and permanent AV block can happen 2.2%. And the risk factor for early mortality is about the RV function. If you have the moderate to severe or severe RV dysfunction, this is a very bad predictor for early mortality. And what about the late mortality? If you follow up, what is the predictor for the late mortality? Of course, this is will be quite the left side. If you have the LV dysfunction, you have high hematocrit, which means that you still have cyanosis, or you have the mitral regurgitation that requires surgery. This is a risk factor for the late mortality. By the way, if you follow up the patient 20 years, you can see that actually survival rate is very good. Well, 20 years survival is 71%. But of course, it's different when you talk about the, free from reoperation. If you remember, 20-year survival is 71%, but if you survive until 20 years, the free from reoperation is just 46%, which means that half of the Ebstein anomaly patients, even they've got the tricuspid valve surgery, after 20 years, half of them will have reoperation. And they try to, see which factor, for example, if you have replacement at very young age, and they believe that, you know, you have the bioprosthetic in the child, and the chance that they develop, you know, valve dysfunction will be higher than when you insert it in adult. And well, when you look at this, you know, number, survival free of late reoperation is different between the repair and replacement only in the group of patients who got the first operation before 12 years old. But if you got the first operation after 12 years old, you can see the survival rate of late reoperation is, you know, quite the same between repair and replacement. Well, let's see, we have the case in my, you know, clinic. This is a 26-year-old man present with palpitation. And of course, we sent him to the EP first. And luckily, he has only one accessory pathway. So he underwent successful IF ablation. And this is a cardiac MRI to show that actually the atrialized portion of the RV is very huge. And this is RV function. The RV function is quite borderline. It's not great, but not bad. Well, this is the timeline of the patients. Well, in 2017, he's got a tricuspid replacement with a, you know, bioprosthetic epic valve and PFO closure. And because, you know, the surgeon told me that after he performed everything, and well, he found that RV function is not good, so he decided to do the Glenn operation. And then after that, just, you know, 2 weeks, the patient has a epicardial lead, RA and RV, because a complete heart block. Well, they wait. That's why they insert the pacemaker. Maybe almost 2 weeks after that, they wait and for a long time, and then they decide that it's going to be a permanent, you know, heart block. So they put a epicardial lead, because if you remember, the SVC of this patient goes into the pulmonary artery already. No way to insert transcutaneous. So they use the epicardial lead, RA and RV. And then the patient follow up. And in the first year, well, the RV function still impaired, but the tricuspid valve is well seated, and there was still my TR. But then we follow up 3 years, just 3 years after that, the patients developed moderate to severe TR and no paravalvular leakage, and the RV systemic function declined. Well, start with borderline and then impair, and then the RV systemic function decline. And then we plan to follow up echo, and then the RV function decline. So we have to do something. So we discussed with the patient, we discussed with a surgeon about the reoperation. Of course, nobody wants to do reoperation in this patient. So this is the echo of this patient with the epic valves, and you can see clearly that the severe TR and the RV function, you know, FAC is 21 and HAPC 1.1. So what we did, we consult with our structural interventionist. And Dr. Man Chanturimon, he's a, you know, group leader for our structural interventionist who perform TAVI, TPVR, and also mitral valve. And well, we discussed about the chance to do valve in valve. So we end up with this patient. We did the valve in valve with the Edward Sapiens in a tricuspid valve. And you can see that the balloon is balloon expandable valve. And then we after this, when finished, we did the angiogram, and then you can see that no TR. So this is our first Ebstein patient that we did the valve in our institute. And then comes the echo after that, and you can see this is the Edward Sapien valve, and no more TR, and still a little bit TS, which happens. Okay, and this is our second case, the same story, that the patient have a severe TR after the bioprosthetic valve, and now we are, you know, are more confident. So we send the patient to Dr. Mann again, and he performed the valve in valve again. And this is our second case, a valve in tricuspid bioprosthetic. And after that, you can see that no TR, and this is a 3D. It's very good. And well, when we talk about the long-term follow-up, one thing that I think that everyone must, you know, keep in mind that if the patient, well, the guideline recommend you to close, you know, the PFO or ASD, but sometimes surgeon left the PFO or ASD because, you know, the RV function is not good. So they think that, which I think is reasonable, that it work as a pop-up valve, And this patient, you can see from the MR, this is a, you know, you can see that they leave this thing like the ASD. So the patient is very cyanosis because it's a right to left shunt. The problem is that if the patient have this shunt, one thing will happen in the future that you don't want to happen, but it happens sometime. Well, patient develop headache, and he's got a multiple brain abscess. So well, he survived. We treat him. He was admitted in the hospital for a long time. He survived, but lately we found that he's got a lot of dental caries. So I think that dental hygiene is also one of the issue that you should concern in the patients with cyanosis, and you have the Ebstein anomaly with still the right to left shunt. Well, if you talk about the follow-up and testing intervals, I think that you can look at this is a 2018 ACC guideline that they recommend, echo. It depends on the physiologic stage of the patient. I think everyone is familiar with this table that they divide the patient into 4 different physiologic stage, while the patient had a heart failure or not, arrhythmia or not, something like that. And if you have the echo, they recommend to do the echo, every 1 or 2 years, MR maybe, every 5 years, or if the patient is in stage D, is every year or every 2 years. And the last thing I want to talk about is about, a pregnancy in Ebstein anomaly, because more and more we have patients, survive until adulthood, and one day they want to, be pregnant, and it's a long time, a lifelong story for the congenital heart disease. And this paper is very good. They look at the clinical characteristic and outcomes in pregnant women with Ebstein anomaly for 9 years, and they have 82 Ebstein anomaly patients, and compare with control group, you can see that the chance that mother with Ebstein anomaly will deliver preterm is higher than control, and also they have higher chance for the postpartum hemorrhage, cesarean section, and this is all the predictor that predict adverse outcomes in women with Ebstein anomaly. Well, what happened with the women with Ebstein anomaly and then they become pregnant? Well, one thing that I think that people ask, will the tricuspid regurgitation will become more severe during the pregnancy? And I found that this paper, I think, come from Japan. It's very interesting because they did the echo pre-pregnancy, during pregnancy, and post-delivery. And they found that for the TR, pre-pregnancy, of course, most of the patient is mild, but then during pregnancy, you can see that, some patients develop from 2 patients severe TR, one patient more during pregnancy and post-delivery, but still not significant. But I think that maybe the number of the patient is not much. Sometimes that's why the P is not significant. But most of the patient can, for mother, no mortality. I think that the most important thing before you do the, pre-conception counseling, in my clinic, we have the nurse who will perform the pre-counseling for the patients. I think the first thing you have to look at our rejection fraction. If there's this is a subharmonic reticular function. The TAP set should be good, and the most important thing is that the mother cyanosis or not. Of course, if the oxygen saturation less than 90% is fine, raise the red flag that maybe you should consider if you want to become pregnant. But I have one patient with a cyanosis, oxygen saturation 89%. During her pregnancy, we have to give her diuretic, but luckily the baby is in term and she's very well, and now everything is so far so good. But if you have the patient with a low oxygen saturation, keep in mind that maybe it's better not to let her pregnant. But I think that my time is up. I just want to say we will have the UCLA conference, and Dr. Liang, our chairperson today, is going to be our speaker for virtual conference, which will happen in Saturday, March. And we have the 2 speakers from UCLA, and we focus on pregnancy in congenital heart disease and the right heart intervention, which Dr. Mann, who will perform the valve in our institute, and also Professor Jami Abu Hors will give a lecture. So if you're interested, you can go to this website and you can registration. So thank you so much for your attention. Thanks.
Thank you, Professor Tarini. We pray that you'll get your full professorship soon. All right, coming up next, let's move over to the next talk. Our next talk is going to be delivered by our good friend, Professor Octave Darrell. Professor Octave Darrell is a consultant ACG cardiologist at the Technical University of München. And he read his medicine at Hanover Medical School in Hanover, Germany. And subsequently, he did his residency in internal medicine and cardiology before furthering his fellowship at the Royal Brompton Hospital, UK. So he received his habilitation degree from Hanover Medical School in 2014, and he's currently an assistant professor at TUM, which is Technical University of Munich, since 2019. And he's going to talk to us about Ebstein anomaly, post-code repair, what to look out for. Over to you, Octave.
Thank you for the kind introduction, MC, and also for the kind invitation. It's a pleasure and honor to be part of this fantastic meeting. I hope everyone can see my slides and
Yes, we can see your slide, Octave.
Fantastic. Okay, so my topic is, as MC said, Ebstein anomaly post-code repair, what to look out for, and I have no conflicts of interest. And the code repair was actually described in 2004. It was more or less invented by Pedro da Silva, who was at that time at Sao Paulo in Brazil. And this was initially published in a Brazilian journal, and they started in 1993 with this operation. And later on, he published his follow-up results in 2007 in an American journal. And if you look at the slides, he describes what he does with this operation. It's a very complex operation. But if you look at the ventricle here, so you look from the right atrium to the right ventricle, and here's the tricuspid annulus where the valve should be, and this is the Ebstein valve. And what they do, and I'm not a surgeon, so I just put it in my cardiologist's mind, but what they do is they just cut out all the leaflets, leaving the entire leaflet here, and then they stitch them all together, rotate them, and stitch them to the true annulus. And then they do application here, and also application of the right ventricle. And they end up with a valve which looks like this. So we have this cone structure here. That's where the name comes from. And it's very interesting. So this is a short video from our institution where they show what they do, the surgeons. I would just put you quick through it. It's just to get an idea how complex this operation actually is. So you have this displacement of the valve. You have to inspect the valves intraoperatively. Even with the best imaging, you can't see everything. And then, as I said, they cut off the leaflets, they call it mobilization. And they do it with all the leaflets, also with septal leaflet, and they try to use as much leaflet tissue as they can. It takes time. And then they start to stitch them all together. I will just show it here. So it's a posterior leaflet. It's a complex operation, as I said. And then you have the three leaflets in here. And then you do the application of the right ventricle, which also needs a lot of attention. So you have to be sure that you don't catch the coronary arteries. Most of them do it now from endocardial, from the endocardial perspective, not from epicardial, just to make sure that you don't catch the coronary artery. And then you create the cone. So you just stitch the leaflets together. Well, a surgeon will probably be not happy if you just say they stitch them together. So as I said, it's a complex operation. It takes its time. And then you have the leaflets together. And what they leave is a pupillar muscles at the apex. So this hinge point stays. And in the end, you have the cone. And then you have to stitch it and attach it to the true tricuspid annulus. And then this is the final result. And this is how it looks like on echo. And the previous speaker already showed the picture of it very beautifully. So it looks differently, but it works very well. And this was the result of the initial cohort from Da Silva, which he reported in 2007. He included 40 patients with a lot of associated heart defects, as previously shown. Ebstein anomaly is not, most of the time, not a single heart defect. And also with a wide age range. So they started with 1-year-old children, but also had adults included. And if you look at the postoperative follow-up, you can see that's quite good. So the echo results are good. And let me just put it here differently to show it to you better. So the tricuspid interregurgitation improves. Tricuspid annulus diameter decreases, which is not surprising if you do application. And this is unfortunately only echo data preoperative and postoperatively before they discharge the patients. And then you have function class, which they evaluated a little bit later. They called the patients, and they could see that most of the patients improved. One patient stayed in NYHA class 4, but quite good results. But if you look at the follow-up period, it's quite short. They had one early death during the operation and in hospital, one late death, and they had to do 2 reoperations, again for tricuspid regurgitation. So at that time point, large centers started to pick up this cone operation. And one of the earliest one was London, and they had 27 patients, which they report in 2015. So even in large centers, you have small numbers, as you can see. Again, a wide age range. Interestingly, they operated on newborns, 22 days. So I think there are 2 centers in the world right now which are very proactive in even operating newborns, and this is probably London and Boston. And again, a wide variety of complex defects. And if you look at the cross-clamp time and the cardiopulmonary bypass time, this is a long and complex operation. They had a mean follow-up 2.7 years. And what they saw, they did cardiac MRIs and they did exercise testing, not on all their patients, unfortunately. But what you can see is, and that's what you would expect, is that RV anti-diastolic volume, diastolic volume decreases, and the LV volumes increase. So this is very good. And what you also can see is early and after the cone operation is that RV function decreases. But interestingly, the forward flow to the main pulmonary artery increases. So the stroke volume is increased, which is very good. Again, the patients feel better. They were in a better NYHA class. Peak VO2 improved, predicted peak VO2 improved. So a positive result, but again, short follow-up, small number of patients. This is our experience from our center. So it was published by our surgical colleagues, and they looked at all patients from 1985 to 2018. And the cone operation was introduced in our center in 2010. And if you look at all the patients, we had 218 in the surgical database. A few of them were excluded due because it was not Ebstein when they actually opened up the heart, or it was a CCTGA. They also excluded patients who were operated initially at our institution, but came from outside. They only wanted to include patients who were initially operated in our institution. So they ended up with 151 patients. And this looks more complex than it actually is. So we had 93 patients with a cone repair at that time. 30 could be discharged with a cone repair. And one of them needed a replacement before discharge. One died in hospital due to multi-organ failure. So the reoperation rate in hospital was quite low. If you look at other repair types, it's much higher. Around 20% of them needed a re-repair or replacement before discharge. So for the initial surgery, which is quite high. But you have to keep in mind, these are different areas of surgery. Right now, the cone operation is the preferred method in our institution. And this is depicted here. So if you look at the time period when they were operated on, to 2010, none of them had a cone, but afterwards, most of them had a cone. So these are different surgical areas. So we have to keep that in mind. And again, the cardiac bypass time and the mean aortic clamp time is quite long with a cone operation. If you look then at the follow-up at the patients, you can see that with the cone operations, most of them are free from more severe forms of tricuspid regurgitation. But keep in mind that the mean follow-up period is quite short here compared to the other group. And again, the reoperation rate is quite low. Again, quite small cohorts. And this is depicted here. So if you look at the mean follow-up, it's 3.7 years for cone patients. For the other pairs, it was more than 16 years. But still very good results for cone in the short-term follow-up. No reoperations needed. Most of them are very good tricuspid valve regurgitation status, actually. So very good results, actually. If you look at survival, I think this doesn't have so much, but at least none of our cone patients died after discharge, but again, small numbers, short follow-up periods. Coming to the Mayo Clinic experience, and this was also discussed previously, they have a huge experience with Ebstein's. I think they right now have 1,400 Ebstein patients operated on, and more than 400 of them with a cone operation. This is the results published in 2018. At that time, they published the results of 235 patients, and pediatric patients and adult patients. And if you look at the age range again, also newborn patients, 6 months old, but also very old adult patients, 73 years old. And most of them was the first surgery, but some of them had previous operations like tricuspid valve repair and atrial septal defect closure. So what these authors say, and they are the ones with the largest experiences, you can reoperate a patient who had a different type of repair for the Ebstein, as long as there's enough enough leaflet tissue left, so you can do it. But at the same time, 111 patients were not suitable for cone. So because they had different operations before, or the right ventricle was not in good shape, or the left ventricle. So most of them were adults, but the cone operation is not for everyone, actually. And if you look at the operative data, you can again see some of them re-repair, but it's a complex operation. It's not just a cone. You have to, most of the time, do different things for them. For example, leaflet augmentation, where you enlarge the tissue leaflets and have more tissue actually to construct the cone. And also different operations like maze operations. And there's a steep learning curve for this operation. So they showed this beautifully and very honestly, actually, that they had a high number of early reoperations in the beginning. And with further experience, the number of reoperations decreased. And this is also what London reported. Most of the reoperations were done within the first patients they operated, and then after learning curve, you're getting better. But if you look at the numbers, the learning curve is steep. Then they showed the follow-up data. Before discharge, most of the patients improved. So tricuspid valve regurgitation went away. RV enlargement was getting better, what we would expect. RV dysfunction, unfortunately, even gets worse. This is probably to an intrinsic myocardial problem. And late echocardiograms were not available in all these patients, those are late, 2.6 years, but still very good results in the midterm follow-up. And this is shown here again. So the fraction area change decreases, and even to discharge. And then during follow-up is getting better. And the index volume for the RV is also getting, it's declining. And if you look at survival, it's excellent, actually. So most of the patients survive, which is very good. And if you look at freedom from reoperation, again, short-term data, it's not 20 years data, but it's very good. Low numbers of reoperations, so very good results. If you look at the Boston experience, another large center who does the cone, you can again see it's still a rare operation. So in a 14 years, 15 years time period, that 157 patients operated on. And what they looked at is, and this is interesting in this paper, is there's a cutoff for age where the number of reoperations increases. And even if it was not statistically significant, it could show that patients below the age of 4 years have a higher chance to need a reoperation for the cone. This could be attributed to different things like well, smaller hearts, more complicated operations. And in these age groups, they don't use annuloplasty rings. So this could be an issue, but still, again, we don't have enough data to support this or that, but it's interesting to see. And if you look at survival, again, they had very good survival curves. So I think that shows in all centers, if the patient is able to get a cone and survives the operation, the survival afterwards is very good. And then they looked at a topic, which is also a topic of discussion, is do you use an annuloplasty ring during the cone reconstruction or don't you use it? So Da Silva in his original report didn't use it. And that's also what we do at our center, our surgeons do, because they learned the operation from Da Silva himself. So they don't use a ring if they don't really have to. Mayo Clinic does it differently, Boston also, they use rings, London also. And Boston looked at this data and they saw, again, statistic not significant, but that a ring might be protective for freedom from reoperation. But still, small numbers, we don't have enough data, but this could be an indication that it works. So if you look at longer term data, there's not much data out there. This is a study again from the London cohort where they did look at MRI data. And you can see the Ebstein patient pre-cone with a large right atrium, small functional right ventricle, and post-cone, which looks much better. And they looked at the cohort, and at that time, 58 patients, 50 of them had an MRI, 24 of them post-operatively. And if you look at those with preoperative and postoperative MRIs, only 12 of them had that. So if you look at these data, you can see an improvement in some variables and then decline others. I will show it more in detail here. And you can see that right ventricular cardiac index decreases actually after this operation. Also, the index stroke volume decreases. But again, as shown previously, the forward pulmonary artery volume increases. So more blood comes to the lungs. So actually, it seems to work. If you look on the left-hand side of the heart, you can see that the LV stroke volume increases, that the antegrade aortic flow increases, and also diastolic volume increases in the left ventricle. So you have more preload, probably some positive septal shifts, and the left ventricle is more happier than before. If you look at the right atrial area, that's what you would expect. It decreases. It also depends on how do you measure it. So there are some people who include the atrialized right atrium, atrial right ventricle, sorry, into the right ventricle assessment. Others don't. So it's depends how you measure it actually. But the functional left ventricular area increases. And again, as shown previously, the left heart area also increases. So there are positive effects, but again, 12 patients. A topic which is also a point of discussion, this is arrhythmias post-cone. So there are some centers, I think Boston does it, which say you have to do an EP study for all patients before they underwent a cone. We don't do it in all patients, we only do it if it's necessary because of known arrhythmia. Mayo does the same, and this is data from the Mayo Clinic again, and they looked at 143 patients, and 108 of them had no EP study before the operations because there was no clinical indication. 3 of them needed an ablation afterwards. It worked. So even through the cone repair, you can get to the point where you need to do the ablation. 2 of them were negative. And the other ones, 35 of them had ablations before due to clinical indications, known arrhythmia. And a few of them needed an ablation afterwards again. Again, it worked and was possible to do. And this is also our experience. So if you need to go and do an ablation there, most of the time it's possible. There are a lot of open questions. So what we don't know in the longer term is what is the quality of life of our patients after this operation. There's some small studies, again from the Mayo Clinic, where they show a short-term improvement in quality of life, especially in children, but we don't have data for long-term. It's the same for the RE function. So we know it gets worse after the operation, but does it have clinical implication as longer term? We don't know yet. And again, we don't know what does it with life expectancy. So are the patients better off if they were operated on or not? And then what's with valve replacement? There are probably a lot of patients, especially in the adult population, who would benefit more from a quick valve replacement operation than a long cone operation, bearing in mind that tricuspid valve surgery in itself is associated with substantial mortality. So I'd like to summarize. The cone repair is a milestone treatment of Ebstein's anomaly. I think this is without doubt, and it is it's due to the genius of Da Silva, who built it on what Carpentier did, and so standing on the shoulders of giants, as I would say, but it is a milestone. But we need more experience. So we need larger numbers. Even if you combine the largest center who do the operation, we are probably around 1,500 patients who receive this operation. So we need more experience, and long-term outcome data is totally missing, and we need that also. Hopefully, this is really a game changer, at least in the short term it is, but we don't know what happens in the long term. Thank you very much for your attention, and happy to answer any questions.
All right. Thank you, Professor Opte Tutarel, for this wonderful lecture. Cone operations has indeed revolutionized how we treat patients with Ebstein anomaly. The reoperation rate has reduced, the patient symptomatically improved. We are very pleased with the outcome. So coming up next, we have a case presentation by Dr. Madan Mohan. And before we present the case, we'd like to invite everyone to post your questions. If you have any questions, please post them in the chat box. Just click on the chat icon and then post your questions. We will direct it to the speakers. And then if you have any burning questions, you would like to raise it by yourself, please go to the reaction icon, click it and raise your hand, and we will let you unmute your mic later on. But this case presentation is going to be brought to you by Dr. Madan Mohan. And Dr. Madan is a clinical specialist at Institute Jantung Negara, Kuala Lumpur, and one of our own locally trained fellows. And he is going to talk about a case with a patient who was operated way before we had the cone operation, and now coming back with some issues. I'd like to ask your opinion, how best we're going to treat this patient. Over to you, Madan.
Thank you very much, Dr. Leong, for the kind introduction. I hope my screen can be seen and I'm quite clear.
Yes, you're getting through to us very clearly.
Thank you so much, then. So let's move on and kick away with the case presentation, right? To present this 25-year-old lovely woman who was diagnosed to have an Ebstein anomaly in 1997 when she presented to us with the refractory supraventricular tachycardia. She was 8 months age at that point. The arrhythmia was aborted eventually with flecainide and was maintained with amiodarone. The echocardiogram done at that point revealed Ebstein anomaly with mild to moderate tricuspid regurgitation, together with the presence of an ASD secundum. She was followed up by our center, and as she progressed on, the severity of the tricuspid regurgitation was worsening, alongside frequent episodes of palpitations. Hence, she was referred for Ebstein valve surgery in 2007 when she was already 11 years of age. Electrophysiology study was done preoperatively, as was suggested by some of the previous guidelines. At that point, there were no accessory pathways found for ablation, and hence she was maintained on amiodarone, and she duly underwent the repair of a tricuspid valve, together with the closure of PFO, ablation of the cavo-tricuspid isthmus in 2008, and the repair was supported with a Kalangos ring of a 28 mm diameter. Intraoperative finding was it was an Ebstein anomaly type C, whereby we know that by Carpentier's classification, type C means that there's a large non-contracting atrialized RV with a very small functional RV with plastering of the septal and posterior leaflets. So the repair was done by a Carpentier's repair technique at that point, as Dr. Leong alluded to before. We didn't have Cohn's technique at that point. Unfortunately, this operation was complicated by severe RV dysfunction. So even though the gland was not part of the initial strategy, we had to go back in a week later and perform a bidirectional gland shunt off pump. She did eventually recover well from this series of surgery, and she was discharged after a total hospital stay of 18 days. Post-discharge, unfortunately, she has been on regular follow-up with no recovery of the right ventricular function. So we've medically controlled her RV failure with a combination of diuretics, beta blockade, and aspirin. In 2017, she represented with an atrial flutter, therefore necessitating the reinstitution of amiodarone to her treatment cocktail. Once it was added on, she reverted back to sinus rhythm. She now remains in New York Heart Association Functional Class 2, and she claims to be able to climb 3 flights of stairs, taking breaks in between. She works as a pharmacist. She is newly married, and she's contemplating pregnancy despite being advised to the contrary by a number of consultants in our clinic. She's also not keen for contraception, and therefore there is a conundrum there. So on physical examination, she's comfortable. She's a bit on the higher BMI with a BMI of 32.3. Her vital signs are otherwise normal with a saturation of 99% in room air. There are no raised JVP, no edema, no hepatomegaly. And cardiovascular-wise, there was no heave with normal heart sounds. Lungs were also clear, and lab results show NT-proBNP is elevated at 818. So I'd like to compare some chest radiographs that was done in 2011 after the surgery in 2008 and compare it with the last chest X-ray we have in 2017. You can see there's progressive cardiomegaly with an increasing of the cardiothoracic ratio to 0.66. The ECG shows presence of sinus rhythm. However, you can see that the PR interval is at the borderline high end of normal, 0.2 seconds, and the QRS complex is also very wide at 200 milliseconds. Interestingly, there are T-wave inversion in leads 3, F, and the lateral leads. So I'd like to show the first echocardiogram that we have post-repair, and there was a TEE done in 2011, and demonstrates classically the skipping rope appearance of the tricuspid valve. And if we look at the next panel, we'll see that there is actually a mild to moderately regurgitant tricuspid valve. See that the RV is very dilated and the atrialized portion is non-contractile. So this is the most recent echocardiogram that we have of her in 2021. And this again highlights the moderately regurgitant tricuspid valve with a very dilated right ventricle and a squashed left ventricle, as you can see over here. You can see paradoxical motion of the interventricular septum, further embarrassing the LV function. It will be highlighted more elegantly in this cross-section view, short axis view. You can see the paradoxical septal motion. Short axis view once again showing the tricuspid regurgitation. And there's a mild pulmonary regurgitation if you look at the RV outflow tract view. But I want to highlight to you here the grossly dilated right ventricle, which is poorly functioning. We've subjected her to a CMR, and this is a function. I apologize for the slow video, but the main thing to highlight here is the grossly dilated RV, swirling of blood within the RV cavity. And you can see that the tricuspid valve is quite prolapsing into the RA with tricuspid regurgitation. From the RV OT view, we can once again appreciate how dilated the RV is. The atrialized segment of the RV is non-contracting. It's only the outflow of the RV that is contracting. Swirling of the blood in the RV. All these shows the same, pretty much. And this cross-sectional view shows once again the paradoxical motion of the septum, interventricular septum. This is the RV inflow view, which shows the presence of the tricuspid regurgitation. And the last MRI that I have is the inflow-outflow tract view of the RV. And this elegantly demonstrates the prolapse regurgitant tricuspid valve and the swelling of blood in the grossly dilated RV. If you look at the RV volumes, so the RV volume is grossly elevated at 461 with the effective ejection fraction of just only 15%. So I had here a comparison of the MRI in 2011. And this is actually anterior here. So this is the RV in the 2011 MRI. The anterior is this. So this is the RV. If you compare it with the recent most, where the RV is actually this one, you can see that the RV, although to begin with was already very poor in function, it's becoming worse. And that's demonstrated in the comparative volumes of RV and diastolic volume. Increase in the RV and diastolic volume. So in summary here, we've got a 25-year-old young woman who's just began her married life, post 1.5 ventricle repair for Ebstein anomaly in 2008. So she's about 14 years down the line. It's been complicated by severe RV dysfunction, does not improve with medical therapy. If you look at the tabulated data across the years, we see that the TAPC is down together with elevated RIMP, suggesting that there is combination of systolic diastolic dysfunction. So her case actually illustrates elegantly the various problems faced by the adult population with Ebstein anomaly, particularly in our region where heart transplantation is out of reach for this group of patients with congenital heart disease. So therein lies a dilemma, and where is the way forward for this patient? So if I can get the host to launch the poll, I'd like to see how could we make an objective assessment of a clinical condition at this point. So all of you can vote at this junction, and there are no right or wrong answers. It's just for us to gauge your assessment of this patient. So how would you go ahead and objectively assess her clinical condition? Would we do serial CMR, serial NT-proBNP? Would we subject her to 2 yearly VO2 max testing, routine assessment of the RV, function parameters on echocardiogram, or all of the above? And moving on then, how could we then improve her clinical status? How many of you will optimize medical therapy, or how many of you will redo the tricuspid valve repair with the Cone's technique, as the first technique was not a Cone's technique? So probably you can start keying in your answers now.
For everyone, you can see that the poll table would have popped up in your screen, and please vote accordingly, and we will share the results. Can we have the results, please?
Can I ask one question, Dr. Liang?
Yes, please.
So right now she is in functional class 3 or 2, right?
2, yes, that's right.
2.
So she's not asymptomatic, she's symptomatic, right? Okay.
Yeah, she does have symptoms on exertion, yes.
And how much diuretic you give to her? Aldactone, how many milligrams?
We are on furosemide 20 milligrams twice a day, and spironolactone 25 milligrams once a day.
Okay. Thank you.
Can the organizers please share the poll results, please? All right, for the first question, it asks us, how do we objectively assess a clinical condition? All right, 13% of people ask for serial CMR, but a far overwhelming majority of people ask for all of the above. All right, which is CMR, serial blood results, biochemistry results, cardiopulmonary exercise testing, and serial echocardiography. Okay, let's look at the subsequent question. Can we improve her clinical status? Optimizing miracle therapy or redo her tricuspid valve repair? I would like to ask the speakers, the two previous speakers, can you please unmute your mic, and we shall discuss her therapy. So the thing about her therapy is that if we were to redo her tricuspid valve, we don't know whether she can take it, because during her first initial repair surgery, she actually did quite poorly. We nearly lost her. And she had low cardiac output syndrome, and she didn't require mechanical support. But then there was long ICU stay, and then we had to do a glen to bail her out. So if we do a redo tricuspid valve repair or replacement, whether this would be a good choice to do. Can we get the speaker to comment? Perhaps start with you, Octave, please.
Fantastic case presentation. Thank you. I think it's a difficult question, but I would agree that I would probably not send her to a cone operation, and due to different reasons. First of all, what do you want to achieve with this operation? So what does a cone operation do? It improves tricuspid valve function. She has mild to moderate or moderate tricuspid valve regurgitation, so it's not severe. So you can't improve much there. So I don't think there will be much of a difference if she improves from moderate to mild. So on the other hand, she has a bad right ventricle. As you said, she needed a glen during the first operation, and the right ventricle is even worse now. And so it's a long operation, a cone operation. Will she be able to get out of this operation afterwards? So will she benefit from it? I don't think so. So even if she sometimes needs a reoperation of the tricuspid valve, I would opt for a replacement and hope that she survives it. So you can try, in my opinion, you can try to optimize medical therapy, but in the end, you probably have to discuss transplantation with her as an option, because everything you do during the operation will not benefit the right ventricle right now, because it's so bad.
Thank you for your comments. The issue with Southeast Asian countries that I don't think heart transplantation is offered in a lot of centers for patients with congenital heart disease, especially those with previous history of blood sensitization, blood transfusion before. So it is not the top of the list when it comes to the priorities for transplantation. But what about you, Tarini? What would you do in this case now? Because our back is pushed against the wall. What would you do to optimize her? And the heart is getting bigger. Medical therapy is just buying us time. Would you subject the patient for surgery, or you think that the risk of surgery is too high? Over to you.
Yeah, I think I agree with Dr. Tutorel that cone operation will not help this patient, because the tricuspid valve regurgitation is not severe. And I think that clearly the patient has the myocardium disease, the RV disease, because the RV does not, as I mentioned before, Ebstein anomaly is the disease of the valve and also the right ventricular myocardium. So clearly this patient has myocardium disease, which, well, even you put the patient on the table, I doubt if the patient can survive from the theater. So, and clearly cone operation does not help this patient. But if she, well, in Thailand, we can do the heart transplant, and I will put her in the first list, in the heart transplant list. But of course, you have to talk with the heart transplant team, because sometimes I put the patient, adult congenital heart patient, to the waiting list, and they think that the patient is young, is not fragile. So they often, just push the patient not at the first priority, but the middle or low priority, which I lost my patient already. I think that clearly this patient should put in the heart transplant. But if the heart transplant list, is not available, or you can increase the medication, because furosemide 20 twice a day, you still have room, to increase the drug. But I doubt if the drug will help or not. What about the sometimes we try Entresto in ANI Entresto. So well, the data is quite limited in the RV. Professor Tutero, you have the experience in Entresto, the ANI in RV dysfunction in this case?
So we published actually our experience with ARNIs, and then it was also a small number, retrospective, short-term follow-up. And in our case, it didn't really improve anything in the patient cohort. It was 23 patients, I guess. So with systemic right ventricle and all that stuff. I can't remember right now if we had Ebstein in it actually, but still it's worth a try, I guess, because there's some data for systemic right ventricle, so mustard patients or something like that, from the Netherlands in a small study again where they showed an improvement, and I would give it a try actually, because I mean you can't lose too much probably, and would give it a try. Also would try. I'm not sure if they're available in your country, but SGLT2 inhibitors, which have the beauty that they don't lead to hypotension or anything like that. So maybe even better for this patient to tolerate. I would just try the armamentarium of heart failure medications, which is available. If it works, fine. If not, we probably have not lost a lot of things in this case. But I think it's different, and it's the same problem with transplantation as what we have here. First of all, we don't have any organs here, not a lot, at least in Germany. It's very difficult to get an organ here because of different policies. So every European country is different in that respect. And the other one is, as you said, it's quite difficult to get in congenital heart disease patients high on the list because, as you said, they look at the numbers and say, well, it's still a young patient. It's not so bad, and so it can be difficult to get transplantation. But I think any other operations you do will, as you said, will make the ventricle worse. It's a myocardial problem in this case. It's not a tricuspid valve problem, not something, at least in my opinion, which could improve with a surgery.
Well, I think that one thing I'm quite concerned is that the patient, she wants to get pregnant, but all the drug that we will give her, for example, if you give her spironolactone, is contraindication for pregnancy. ARNI is contraindication. So the drug that can save her life will kill her dream. So I know it's different. I know it's different, but I think that, well, I will put, I increase furosemide. I will add maximum dose of aldactone and maybe put ARNI. But I have to talk with her husband about the contraception. You know, sometimes, I don't know, but for me, sometimes I have the patient that the problem is not the woman, but the husband.
The husband.
So you have to talk with the husband. Yeah, you know, I don't know if you have this problem or not in your country. Yeah.
Yeah, I guess we have the same problem throughout Southeast Asia. Yeah, sometimes it's the woman trying to tie her husband with a child. So coming back to the patient, and if you look at points to ponder the third point on the role of biventricular pacing, we can see that, you know, the medical therapy doesn't help much. We just symptomatic control, and then we're wondering whether there's a role of biventricular pacing, do a synchronization therapy. But if you look at the ECG, the QRS duration is about 200
milliseconds.
Yeah, would it be a good candidate for biventricular pacing, try to improve the function via pacing, or are we trying to pace a very sick RV and it's the RV just give way? Your comments, please.
My son, can you show me the EKG again?
Yeah.
Was she already paced or not paced yet? She isn't paced, isn't she?
She's not paced.
It's not being paced at the moment.
Sorry.
Just want to see whether if this patient would benefit from a resynchronization therapy. Bearing in mind, this has to be done by epicardial methods because of the gland.
Well, Dr. Tuchero, you want to talk first or me?
No, go ahead.
And I'm just sorry. You can stop me. Okay.
No worries.
Well, you know, for the CRT, I think that I doubt about the role of this CRT because most commonly the CRT used for the LV dysfunction, and this is clearly this is RV. And even if you put, I look at the MR, and actually I doubt if the myocardium with RV that you have the scar already or not, of fibrosis, because it seems like that it does not contract at all. So if the whole myocardium of the RV does not contract, I don't think it's a good point to put the the lead just to make it contract because I don't think it will improve. But I don't have experience putting the CRT in the RV dysfunction. I don't think it will work in this case. What about you, Dr. Tutorel? Yeah.
I would tend to agree actually, because I think you could give it a try, sure, but as you said, I mean, it's not just you need to do an epicardial lead, then you have to find a place where you can put the lead on. Actually, if you look at MRI, there you have to find viable myocardium where it really works, and at least from the pictures, didn't seem to be a diastolic problem actually, because it's just the myocardium is not good, it's just not working. But still, if you have no other options, you could give it a try. So you can do it with a minimal invasive surgery, with the placement of the epicardial pacemaker lead, and give it a try if it works. I mean, if you don't have any other options for this patient, I would try. Actually, I would try everything if it's possible, but I would be not very optimistic that it helps. I think it's very difficult to predict which patients with systemic right ventricular, I think that this is where the most experience comes from with CRTs, which is again 20 patients, 30 patients. It's difficult to predict which of them will profit or benefit from a CRT. So as you said, if you don't have any other options and in a lost situation, you could give it a try, but I would not be very optimistic that it really helps and improves her outcome.
I think there is one suggestion from the audience that's interesting. Are there any role of the RVET in this patient? I don't have experience in RVET. Do you have any experience in RVET, Dr. Tutorel?
I mean, yeah, you can put an RVET in, could help. Again, different from country to country, if we could put in this as a bridge to transplant or as a destination therapy. There are results for RVETs. They work in experienced hands. So this would be a solution for some time. So I don't recall any patients with an Ebstein looking like this who get an RVET, but you can do it. It works. But again, I would advise you to get pregnant with an RVET. So I think you have to have an honest discussion with this patient regarding also her husband and her family regarding pregnancy and pregnancy outcomes and all that stuff. And that I think what Lorna Swan and Lon always told us is always good to tell the husband that he will probably end up as raising the child alone after pregnancy. She can keep this in mind. And I think you have to be a very honest discussion with the family regarding pregnancy, and I would not advise to get pregnant. But I mean, people do what they do.
All right. Coming up next, let's pop over to the fourth point on that. All right. What about the role of thromboembolic prophylaxis? We know that the RV function is pretty bad, and there's sluggish flow within the RV. And would you start warfarin on the patient, because this is based on what we learned from the LV heart failure? Would you start the patient on warfarin, or would you start the patient on OAC, or would you think that double antiplatelet therapy will be adequate? Why don't you start off?
Oh, you first, Dr. Tutorel.
Ladies first, you have to. Yes.
No. Oh, I'm not a lady here.
Okay. So being a cardiologist, platelet therapy won't help here. So if you can do dual platelet therapy, and that I mean, if you have a problem in the LV, like a thrombus, something like that, so platelet therapy doesn't help with sluggish flows and all that stuff. So if you want to do an anticoagulation, in my opinion, you have to do it with warfarin or with an OAC, if that's possible. It's really difficult to decide. I mean, she's still in sinus, so I mean, it's a difficult question. My gut feeling would be to put her on some kind of anticoagulation, because I would expect that in between she will get atrial arrhythmias if you look at this heart, and probably arrhythmia if we don't detect. and but without any evidence behind it. It's just my gut feeling to discuss it with her. But again, then you have to take this pregnancy thing into account, and if they still want to go ahead with pregnancy, I wouldn't anticoagulate her, because you mess up a situation which is already messed up.
Yes, I totally agree with the tutorial. Yeah, I agree with your gut feeling. Yeah, because many times, yeah, of course, many times in congenital heart disease, you cannot follow the guideline 100%, you know. But when you see number of cases and you know that this patient will have something happen in the future, I will give her anticoagulant. Yeah.
Oh, okay. So the last question, would any of you allow her to get pregnant? Or if yes, what would you do to optimize her heart before allowing her to get pregnant?
No, no, not at all. No. Dr. Tutorial, what do you think?
As I said, I wouldn't disagree right now. I wouldn't advise her for pregnancy, and I think you have to be very honest, very blank with the patient and the family, what the outcome will be and could be. And regarding optimization, I think, yeah, you could increase diuretics in before you could stop fetotoxic medication, but still the outcome will probably be not good, especially concerning longer term outcomes. So I don't think if she gets pregnant, even if she survives it, she will probably not be able to see her child grow up. And I think you have to be very honest and just tell her that everything's high risk, not only for herself, but also for the child. I mean, how high are her chances to get a viable pregnancy and a child? I think you have to be very blank. But as I said, I mean, probably all of us have this experience. Patients still get pregnant. Even Eisenmenger patients get pregnant, despite advising against it. And then you have to do the best. But you can't probably do much more than diuretics and maybe a little bit beta blockade. But I mean, I don't think that will really be safer. Yeah. So I would agree, no.
Thank you.
So I think we have agreement over here, no pregnancy for her. So we have an interesting comment from one of our audience, Farhan. He said that this patient has very poor RV function. There's right bundle bunch block QRS duration is about 200 milliseconds. Is there any role for AICD for primary prevention of sudden cardiac death? Harini, I noticed that you mentioned about sudden cardiac death prevention just now. And do you mind giving your comments on this matter?
Well, as I mentioned before, the primary prevention does not have, it's not a class 1 indication in congenital heart disease because the data is not as strong as non-congenital heart. Well, but if you look at this patient, I totally agree that the patient has many predictors for sudden death, heart failure, ejection fraction poor, subpulmonary, and a QS complex. Although the QS duration we use is for repair tetralogy follow, not for Ebstein anomaly. But for me, I think that any RV dysfunction that's so bad that, well, it can lead to, sudden death. The problem is that this is not going to be the class 1 indication, and you cannot insert the ICD subcutaneous because the patient have gland operation already. So the only way you have to open the chest and put it, in a sub, epicardiously, which I doubt if the patient will survive after the surgery. Well, I don't know. For this case, I don't want to insert the ICD. What do you think, Dr. Tutorial?
I think it's very difficult. As I said, I mean, the data for primary prevention in all ACHD patients is not very good. In Ebstein's, it's probably even worse. Again, as I said, if you look at this RV, you don't have a very good feeling, and you have the feeling you have to do something. I would again discuss it with the patient. I'm not sure if subcutaneous ICDs are available in your country. This could be an option in this case, so you don't have to put in lead and have some kind of protection for the patient. But there's not a hard case to put it in here actually, because as you said, and we have patients who die from sudden cardiac death, but none of them in Ebstein have this typical like bad ventricle and all the stuff. Some of them just die from sudden cardiac death, and you don't know why. And it's a difficult discussion. You can put in an ICD, you can make a case for it, but then I would opt for a subcutaneous one.
All right. So being true to our ASEAN ACC webinar team, we were thinking, why don't we just get some opinions from, our colleagues from the rest of the ASEAN countries. Now we have here together with us today is Dr. Tan Julie from Singapore. And Julie, do you mind unmuting yourself? And would you treat the patient differently, or would you do the same? Your comments, please.
Can you see me?
Yes.
Yes.
Yes. Hi. So I enjoyed the discussion very much today. Thank you for an excellent session. And I think this is a very difficult patient. And I agree with both speakers on their comments. And I didn't feel that doing another valve operation would do justice to her. I think the whole problem is RV dysfunction, and it's difficult to treat. And I think her survival will really depends on how long the RV will hold. So I think maximizing medical treatment, I think there's still avenue. I agree to increase the diuretics to offload the RV a little bit. Again, you can try ANI, but again, not proven. I'm not sure whether it'll work. And also you have to watch out for hypotension and things like that, and to see whether she can tolerate the ANI dose. I agree, if there is a facility for heart transplant, she should really be referred for assessment of heart transplant. I think that's probably the kind of only thing. I have nothing else to add about CRT, and I have no experience. I'm not sure whether it will work for the RV or not. I think the data is very sparse. Yeah. And certainly I would agree. I don't think I would advise her against pregnancy. I think the risk is too high. And I think she needs to understand the facts, where she's going. I think she also needs to understand, even if miraculously she has a child, eventually what is the lifespan going to be like, and who is going to look after her child. There's all this issue as well. Yeah, thank you.
All right, thank you, Julie. With us today also we have a Dr. Anna Ulfa from Indonesia. Dr. Anna, do you mind unmuting yourself and give your comments regarding this patient? Would you do anything different in managing this patient?
Yes, I enjoyed the presentation. This is truly a very difficult case, and I think the only option is, as has discussed and mentioned about the medical treatment in this case. I wonder whether pulmonary vasodilator will be useful in this case.
Right. Octave, you want to, this time now, would you like to comment first? Would you think that giving pulmonary vasodilators will help to offload the right ventricle and helps the right ventricle function?
I mean, if she has some indication that she has raised pulmonary pressures, then again, you can give it a try, but I don't think that this will help her a lot. But I know, so I'm not a pediatric cardiologist, but I know the pediatric cardiologists tend to give sometimes sildenafil and hope it helps, and sometimes it does. So you could give it a try, but I don't think that will help a lot, because as previously said.
All right. Okay. I think
it's a myocardial problem. It's not a problem with too much pressure.
I think its time's almost up. I think we have time for one last question. Okay, we screen through. If we screen through the chat box, we see that we have one question from Dr. Anna, and which says that but in what case would you think that you would straight away go for a tricuspid valve replacement plus a bidirectional gland? Do you have a figure in the RV function? A specific number, magic number, below which you think that this patient will definitely need a gland during tricuspid valve repair, right? Octave, do you want to start off?
I don't think there's a magic number. So you have to look at the whole picture, I guess. So you have to look at the RV function. how large is the RV, and how's the LV looking. So I think there's no magic number. I think the Mayo Clinic has a protocol for when they do a gland, but I can't recall it right now actually. But in no institutions, there's not really a magic number for that, but more the whole picture.
Tarini, you want to comment on this?
Yeah, I agree with Dr. Tutorial. We don't have the magic number to decide which patient should get the gland, which patient should not. And actually, in my institute, the patient who received gland, actually we kind of during the conference we say that maybe the patient should get gland, but during operation and after they close everything and they found that the RV does not come back, then they have to open and put the gland. That's the case in my institute. So I don't think, I think it's case by case. They look at in front of them and check. What do you think, Dr. Tutorial?
Yeah, I think it's also something we often end up in a conference that the surgeon says he will decide it intraoperatively. So I mean, you say it's a borderline case, and then they say, okay, I will take a look during the operation, and then I will decide to do a gland or not. As I said, again, there are surprises. You do a cone or whatever, and then the ventricle is very good and working, and you don't need it. And then the other ones, the ventricle is not working, then do a gland. So as I said, no magic number, actually.
In such a poor RV condition, would we consider maybe just downsizing the ASD as opposed to fully closing off the ASD just to keep a pop off in future? I mean, if we are facing a very bad RV from the word get-go.
To achieve what? So you want to make the ASD smaller?
Just instead of closing the ASD fully and then worsening the preload on the RV, which is struggling. Okay. Yeah. You think a small PFO or something like that could help. Increasing the preload to the left ventricle, sustaining cardiac output, those kind of stuff.
Yeah. I mean, totally agree. So sorry, I just went ahead, but I totally agree, and that's also at least in some institutions to the politics. If you do a cone, that you leave the ASD open. Mayo just close it. The Silver leaves it open with this idea to have some kind of a shunt possibility. Mayo says, so Derani says he doesn't believe it's enough. You need a gland if the ventricle is not good. But yeah, I wouldn't totally close the ASD in this case. And if it's closed, could be a bailout option for a short time that you open up the ASD again. But again, in this case, you have a gland anyway. So if that doesn't help, it probably doesn't. What could be a bailout option, which would be, you could consider to convert if it's possible, but it's very difficult to do in Fontan in this case to complete the heart. But again, I don't know. I think there's only anecdotal experience with that, with such a ventricle and late Fontan conversion. But I don't know. You could try if you're totally desperate.
But doing Fontan in a 20-plus-year-old would have its own problem as well. The risk of surgery and the risk of Fontan in a 20-plus-year-old lady. So it's going to pose a new challenge to us. And I think that's all the time that we have. It's been 9:30, and we really like to thank everyone. Thank you everyone from joining, especially the speakers, Professor Octave Tutarel and Associate Professor Tarini. And thank you so much for sharing your thoughts, your experience with us. And if you like this program, we have another 4 more webinars coming up. We have it every Thursday, 8 to 9:30. If you've liked this program, do share with your friends and colleagues, ask them to join us. The more the merrier. We'd like to have more opinions, exchange of ideas, and so on and so forth. And next Thursday, we're going to have a discussion on Fontan and how we can optimize the Fontan circuit, right? With this, I thank everyone once again for joining. This is Dr. Leong Ming Chen. I'm from Institute Jantung Negara, and I'd like to thank everyone for joining this webinar. Thank you, and see you next week.
Thank you.
Thank you.
Thank you.